We are here with the last working group, number 4 of the Perio Workshop. It's about acute periodontal diseases. And I would like to start with you, David. We have the chairman with us, David Herrera, and also Panos Papapanou. And I will start with you, David, asking about a general question about which is the main focus of your working group, and if you can outline the key objectives.
Thank you, Spiros. Working Group 4 was dealing with acute periodontal conditions, as you have said. So we have 3 conditions. 2 of them are always acute: necrotizing periodontal diseases and periodontal abscesses. The third one, endodontic periodontal lesions, can be acute or chronic. The objective of our group was to provide guidance in order to help the clinicians, first, to identify these lesions, because you need to diagnose these lesions very quickly because you have pain, active distraction, and you need to provide treatment almost immediately. So this is completely different to everything else that we have in periodontology, in which you will have some time to prepare the diagnosis, even extra tests. Here is not like that. You need to be very fast, very quick and accurate, and then provide the diagnosis. And we've been discussing which is the best approach for that diagnosis, the immediate treatment that you should provide, and then which is the follow-up, the subsequent treatments that you may need to implement too.
Okay, thank you very much. Let's start immediately with the most complex topic, I think, in my opinion, or maybe many clinicians think so, about the endoperiodontal lesions. And I would like to ask you, Panos, if you have any guidance to give to the clinicians today, how do they should treat it to reach the prognosis and go even further with that?
So as with many of the conditions within our sphere here that we discuss, the accurate diagnosis is paramount, because this is what guides the subsequent steps, as David said. So as all clinicians know, in the endoperio situation, you have in the same tooth a combination of lesions. One can be of periodontal origin, one can be of endodontic origin, and those 2 lesions meet. So one of the questions that we dealt with the group that are very important clinically is what is the timing and the sequence of those treatments. So we had very nuanced discussions, because there is obviously a risk for over-instrumentation if you perceive the lesion to be reaching the apex, but you still have some vital periodontal ligament. Then you treat the tooth endodontically. You want to achieve the maximum of repair due to the endodontic damage, and then you intervene periodontally. So, unfortunately, a lot of our recommendations are based on common sense and clinical experience. There are some studies, but a lot of the burning issues that we have not been addressed by formal RCTs. And this is where it becomes both challenging and interesting to work with a group of many talented clinicians, because everybody brings something to the table. But I'm not suggesting that this is rocket science or anything, but I mean, what we try to do is to give a list of sequential actions that are based on biology, on evidence, and on clinical experience. And I think we had a lot of interesting discussions in the group, and I think the clinicians are going to find the final script useful. So
I hope so. And what about periodontal abscesses? I mean, they can compromise prognosis of a tooth. What we should do?
Yeah, correct. So periodontal abscess is most often associated to pain, but also to rapid active destruction of the bone. So it will compromise the prognosis of the tooth. And so first, again, you need to do the appropriate diagnosis. And once you are sure that it is a periodontal abscess, it's a critical step to drain the abscess. And this is the way all the abscesses in the body are treated. So drain the abscess. No antimicrobials, no systemic antibiotics. Those antibiotics will only be used when you don't have the chance to drain, because the patient will need a premedication or because the abscess cannot be drained due to anatomical conditions. And then you need to follow the patient after 2-3 days to check that the pain has disappeared, that the void elevation has disappeared. And if that's the case, then you wait a little bit more, and then you provide treatment, subsequent treatment, usually to treat the pre-existing periodontitis, because these abscesses normally will appear in a deep pocket, or sometimes it's associated with food impaction or with habits, and then you need to change the predisposing factors. But the most important thing, drain the abscess.
Yeah. The way I see it for both, no problems, timing is very important. Timing for the intervention is also very important, plays a role. What do you think, Pan?
Absolutely. And again, in certain situations, I mean, if you mismanage the case and the abscess can spread in other anatomical spaces, I mean, the patient can be in real jeopardy. So that's why both diagnosis and timely intervention is of paramount importance. And again, we try to provide some scenario and some sequence of advice that I think clinicians will appreciate.
Yeah, the systemic consequences of periodontal abscesses have been reported, and the bacteria through bacteremia can travel all over the body and can cause infections in other parts of the body. But also at the local level, waiting 2-3 days to control the abscess may give the affected tooth a hopeless prognosis. So it is, as you have said, important to immediately take immediate action with these conditions.
Okay, and one last question to both of you. We're going to start with you, Panos, about necrotizing periodontal disease. It's a big chapter where pretty much the clinicians, they feel stressed to deal with that. Could the workshop help on that direction?
I hope so. I'm sure it does. We're talking now about conditions that are not very common, at least in our parts of the world. I mean, it's not tons of patients that we have seen. So, traditionally, stress has been incriminated, excessive smoking, stress during exams for students and younger individuals. Of course, our students now are not so stressed, so we see less and less of it. But at any rate, in most situations, there is a pretty predictable way of dealing with them. I mean, you have to alleviate pain, you have to clean the mouth. So the principles are not very much different than how you treat traditional periodontal lesions, apart from the fact that you have a distressed patient that may be in a situation of pain. So that's a challenging thing, how you're going to do the intervention, do maximum good without really torturing the patient. And there are ways around this. And then I think David is going to talk about the real big issues that are necrotizing diseases in other parts of the world that are less affluent, where the consequences can be much more severe than what we see here.
About the extremes.
Yeah, the thing is that for necrotizing periodontal diseases, you need to have a compromise in your immune system. It's not working properly. This could be just a temporary thing, a moderate thing, like what we see in the industrialized world, as Panos has explained, so stress during the exam or too much smoking. But the compromise of the immune system could be also long-term, chronic, and more severe. And then the necrotizing periodontal diseases that we see can be really, really serious and progress from affecting just the gum, necrotizing gingivitis, then the bone, necrotizing periodontitis, then the skin, the mucosa, necrotizing stomatitis, even the whole mouth and the whole face, which is called NOMA, which is a very serious disease. It may, most of the people who will suffer this disease will die, and those who do not die, they will regret being alive the rest of their lives due to this sequela. And this is a neglected tropical disease, and the World Health Organization is now paying a lot of attention to this condition. It is mainly found in Central Africa, and these people has many other health issues and life issues, is in children. And so it is, we're talking about most probably the most serious disease associated with the bacteria of the dental biofilm.
And also associated with malnutrition, which is a predisposing factor in this community. So you talk about sub-Saharan Africa, where you have a lot of kind of infections and malnourished children. And that's where this becomes tragic, because it is preventable, but it's a delayed reaction, neglect, predisposing factors. So it becomes the most extreme scenario that you can encounter.
Yep.
Thank you very much for that detailed presentation of the important work in your workshop and your working group, and I wish you all the best guidance and results. Thank you very much for being here.
Thank you very much, Spiros.
Thank you.